Good evening everyone. I am going to present my paper, The Change in Occupancy Ratio and Fatty Infiltration of Supraspinatus Influence Functional Outcome After Single Rotator Cuff Repair, an MRI Based Study. So when we see a patient with rotator cuff tear with good amount of fatty infiltration and a big tear, the question which comes in our mind is, should we repair it, because we have a fear of re-tear, whether it is going to give a good functional outcome or not, and what will be the healing. So what happens when a cuff got tear? It leads to change in pattern of the muscle fiber, that is increased pination angle, and separation of the muscle fiber, that is sensed by the mesenchymal and fibroadipogenic progenitor cells that lead to fatty infiltration. So muscle atrophy and fatty degeneration are regarded as the most important prognostic factor of cuff repair. So how can we measure muscle atrophy? As suggested by Thomasio et al., where we have to take the sagittal oblique view in MRI T1 weighted image, we have to measure first the supraspinatus fossa area, we have to measure the supraspinatus muscle area, and dividing these two we can get the occupancy ratio, which is the indirect measure of muscle volume. Similarly, we can grade the fatty infiltration as per Gottelier grade from grade 0 to grade 4, grade 0 normal and grade 4 where more fat than muscle. So what is the controversy in literature is the muscle atrophy and fatty degeneration are irreversible change as by Gladstone and Gottelier, where some author claims it can be halted or reversed, like Gerber and Thomasio et al. And recent study by Park et al., where he find that muscle volume improved, but there is no change in the fatty infiltration in a serial MRI. If you correlate those two things with the functional outcome, what we find by the study of Gerber, where he find the rotator cuff muscles and developed tension not only correlate with their atrophy, but also closely correlate with their degree of fatty infiltration. Similar by finding by the Sen et al. But the lacuna in literature is there is very limited study correlating this functional outcome with the occupancy ratio and fatty infiltration. And in this study, mostly the supraspinatus tendon tear included and repair done with combined method of treatment. So in our study, we included both isolated and combined tendon injury, and all were repaired by the single technique. So the aim of the study was to evaluate whether preoperative muscle atrophy and fatty infiltration of the cuff improve or reverse after cuff repair, how it influences functional outcome, and to analyze correlation of this with the re-tear. So it was a prospective observational study done at Ganga Medical Center. And in a sagittal view, in T1 weighted image, we measured the occupancy ratio and fatty infiltration, and all sections of sagittal and corneal image intubated, we find out the repair integrity. So all patients having the full thickness rotator cuff tear who underwent single row cuff repair arthroscopically included in the study, and at least they should have a minimum 6 months of follow-up with 2 sets of MRI. And excluded from the study were those having the slab tear, Bankart lesion, rotator cuff repair with double low technique, these were excluded. So in this duration, we have a 210 patients with cuff tear repaired, out of which only 52% we could include because their pre-op and post-op MRI was done at our center. So all the patient assessment clinically at 6 months with SS score, constant score, and nuclear score, MRI evaluation was done at 6 months. And healing were graded as suggested by Sugaya et al. From type 1 to type 5. So our result, we find that minimum mean age of the patient were 56 years with the duration of symptoms for last 4 months with duration of follow-up 16 months. And out of this 52% isolated supraspinatus, 18%, supra with infraspinatus 19%, 9% with all 3 tendon injury, and supra with subscapularis in 6%. So muscle atrophy, what we find in pre-op was mean 0.56, which got to 0.50. That means there was a significant increase in muscle atrophy in spite of a good repair and healing. When we see in the combined tendon injury, what we find is those patients having the multiple tendon injury, those were having the more muscle atrophy, means their occupancy ratio were on the lower side, but it was not statistically significant. When we see in those patients with the fatty infiltration, what we find as in grade 9% have the grade 0 fatty infiltration, and after repair 4 of them went to grade 1 and 2 of them grade 2. Similarly for the grade 1 and grade 2 fatty infiltration patients. So their fatty infiltration got increased, and that was statistically significant. So significant increase in muscle atrophy and fatty infiltration post-operatively in our study, similar to the study by Lim and Gladstone et al. When we see the functional outcome, we find out that those patients having the lesser fatty infiltration, they are having the good functional outcome, but that was not statistically significant. In the combined tendon injury, we found out that in spite of having the multiple tendon injury, all patients got a good functional outcome, but those were having the all 3 tendon injury, they were had compared to other group, they were having the lesser functional score, and that was statistically significant. So functional score was having a positive correlation between pre-op muscle atrophy, and that was similar to the study by Sen et al. Out of 52 patients, we got a 2 patients with asymptomatic type 4 tear, and supraspinatus muscle atrophy was lesser in that, and lesser in that case. So atrophy was predictive factor of post-operative re-tearing in our study, which is favored by Thomajo et al. We have both 2 patients of re-tear. 5% of grade 3 fatty infiltration, although they are having lesser occupancy ratio, but they have good functional outcome. So to conclude, muscle atrophy and fatty infiltration are irreversible phenomena and continues even after successful repair. However, it does not significantly influence functional outcome in short-term follow-up. Repairing of cuff, even higher grade of fatty infiltration, can be performed as they achieve optimal functional outcome without repair. Thank you.
Thank you very much, Dr. Jha. Any questions from the house? Did you segregate your patients from traumatic tear to
Most of the patients were degenerative. We have not segregated them, but all the patients what we find in our study were degenerative cuff tear with minimum mean follow-up, mean symptoms of last 4 months.
Majority was degenerative.
Degenerative tears.
And the post-op, you just did 1 MR after 6 months.
Yeah, 1 MRI after 6 months, and 6 months we evaluated clinically with all the scoring system, and we used to follow them. If there is deterioration in the clinical symptom, then only we went for the MRI, otherwise not.
Yeah, thank you very much.
Thank you.